Recording. Good morning, everyone. The topic for today's presentation is pharmacotherapy in dementia, and my moderator is Dr. Sanjeevani ma'am. Dementia may be defined as a syndrome of persistent acquired cognitive deficit sufficient to affect the function. Dementia is an increasingly important and prevalent problem. The number of elderly patients are increasing, especially those up over the age of 85 years who are at highest risk. Affects around 5% those aged above 65 years and increases to 20% aged over 80 years. This disorder is characterized by cognitive decline, impaired memory and thinking, and a gradual loss of skills needed to carry out activities of daily living. It has changes in moods, personality, and social behavior. Dementia is also encountered in about 30 to 70% of patients with Parkinson's disease. Now, the management. The treatment of dementia requires a multimodal approach. It not only targets the cognitive deficits, but also addresses the neuropsychiatric symptoms and overall level of function. The treatment modalities and strategies will vary with the stage and type of dementia. Educating patients and their families about the course of the illness and providing individualized treatment plans that ensure safety and adequate levels of care are essential. Now, the evaluation. The initial workup includes a complete blood count, chemistry profile, thyroid profile, and vitamin B12, neuroimaging with CT and magnetic resonance imaging. Depending on the history and clinical findings such as ECG, EEG, urine analysis, sedimentation rate, and folate levels can be done. Occasionally, screening for heavy metals or inflammatory conditions such as systemic lupus erythematosus may be considered. PET scanning is not routinely performed today, but may be useful in distinguishing Alzheimer's disease from frontotemporal dementia, such as Pick's disease. Now, the pharmacotherapy. Treatment of dementia is currently symptomatic rather than disease modifying. There are three treatable symptoms of dementia: psychosis, the memory, and agitation network. Each network is regulated by each symptom is regulated by a unique network. Now, the first is the acetylcholine and glutamate can be targeted by acetylcholinesterase and NMDA antagonists. The psychosis network can be targeted at the serotonin node as well as the dopamine node. The agitation network has a multimodal neurotransmitters action to improve the agitation. Now, the Alzheimer's disease. In Alzheimer's disease, there are amyloid precursor proteins which are cleaved at the A beta level, A beta site in a non-amyloidogenic pathway. But in amyloidogenic pathway, beta secretase and alpha secretase cleave the protein in such a way that A beta plaques are formed. A beta proteins are formed, which forms A beta isoforms, in which A beta 43 is a rare isoform and has the maximum prone to aggregation, and A beta 40 is the least prone to aggregation. This amyloid A beta protein forms plaques, which leads to hyperphosphorylation of tau protein and forms neurofibrillary tangles. Now, there are potential disease-modifying treatments, which are agents targeting A beta pathology, which are anti-amyloid antibodies, active A beta immunization, beta secretase inhibitors, gamma secretase inhibitors, and alpha secretase promoters, A beta aggregation inhibitors. Now, there are agents targeting the tau pathology, which are anti-tau antibodies, active tau immunization, tau aggregation inhibitors, microtubule stabilization, and tau phosphorylation inhibitors. Now, first is targeting the acetylcholine. It is a symptomatic treatment of memory and cognition in Alzheimer's disease. Cholinergic dysfunction accompanies age-related cognitive decline due to the early loss of cholinergic neurons from the nucleus basalis. The most successful approach to the intermediate treatment of cognitive and memory symptoms of Alzheimer's disease is to boost cholinergic functioning by stopping the destruction of acetylcholine by acetylcholinesterase inhibitors. Enhanced availability of acetylcholine is proven to impact cognitive and memory symptoms, but more often helping to retain current levels of memory function and thus slowing the decline in the memory. These are the projections of memory network which project from basal forebrain to the hippocampus and neocortex. In the when there is aggregation of plaques and tangles in the basal forebrain, it disrupts this memory network, which leads to memory loss. With cholinergic treatment, it boosts the memory network, but with progression of the Alzheimer's disease, this destroys the cholinergic treatment, and its cholinergic treatment is ineffective. In acetylcholinesterase inhibitors are acetylcholinesterase inhibitors include donepezil. Donepezil is a reversible, long-acting, selective inhibitor of acetylcholinesterase without inhibition of butyrylcholinesterase, which is also known as pseudocholinesterase. Donepezil inhibits acetylcholinesterase in the pre- and postsynaptic cholinergic neurons and in other areas of the central nervous system, including which are outside the cholinergic neurons, where this enzyme is widespread. Donepezil also inhibits acetylcholine in the periphery, where its action in the GI tract can produce a GI side effects. Now, the starting dose of donepezil is 5 mg daily, and the usual or maximum dose is 10 mg daily. The recommended minimum level between the dose increases is 4 weeks, when it is increased by 5 mg daily. Rivastigmine is a pseudo-irreversible, which means it reverses itself over hours. It's an intermediate acting. It's not only selective for acetylcholine over butyrylcholinesterase, but perhaps for acetylcholinesterase in cortex and hippocampus over acetylcholinesterase in other areas of the brain. Rivastigmine also inhibits butyrylcholinesterase within the ganglia where it is produced. Inhibition of butyrylcholinesterase within ganglia may even be more important in patients with glia, can be more important in patients with Alzheimer's disease as they develop gliosis when cortical neurons die. Rivastigmine appears to have a comparable safety efficacy to donepezil, although more GI side effects when they are given orally, so transdermal patch is preferred. Rivastigmine appears to have comparable transdermal patch is also available. Starting dose is 1.5 mg BD orally or 4.6 mg per 24 hours patch. Maximum doses 3 to 6 mg BD oral doses and 9.5 mg 24 hours patch. The recommended minimum level of between dose increases 2 weeks for oral, increased by 1.5 mg twice daily, and 4 weeks for patch, where it is increased to 9.5 mg per 24-hour patch. Galantamine is has a dual mechanism of action. Acetylcholinesterase inhibition is with positive allosteric modulation of nicotinic cholinergic receptors. Theoretically, inhibition of acetylcholinesterase could be enhanced when joined with the second action of galantamine and the nicotinic receptors. However, it has not been proven that the theoretically advantageous second action has a nicotinic positive allosteric modulator translates into clinical advantages. The starting dose is 8 mg extended release daily or 4 mg BD solution. Usual doses is 16 to 24 mg of extended release milligram daily, 8 to 12 mg BD solution, and the recommended minimum level of dose increases is 4 weeks and increased by 8 mg daily. These 3 drugs are now also recommended in severe Alzheimer's disease. Rivastigmine is licensed in the treatment of mild to moderate dementia associated with Parkinson's disease. The 3 acetylcholinesterase inhibitors seem to have broadly similar clinical effects as measured by the Mini Mental Status Examination and Alzheimer's Disease Assessment Scale. The benefits of treatment with acetylcholinesterase are rapidly lost when drug administration is interrupted and may not be fully regained when drug treatment is reinitiated. Significant proportion of patients, up to 50%, appear to tolerate and benefit from switching between acetylcholinesterase if they cannot tolerate one, as per the revised British Association of Psychopharmacologically Guidelines of Dementia. Gradual withdrawal should be carried out because of several cases of discontinuation syndrome from abruptly stopping donepezil. Acetylcholinesterase inhibitors is not recommended in individuals who show loss of benefit several years after initiation of the therapy. Acetylcholinesterase may also affect non-cognitive effects of Alzheimer's disease and other dementias. Efficacy of the three acetylcholinesterase inhibitors in relation to severity of Alzheimer's disease found that the efficacy of drugs was independent of dementia severity in all domains. Now the dosing. Rivastigmine transdermal patch, which is 9.5 milligram per 24 hours, has been shown to be effective. The FDA has approved a higher daily dose of donepezil sustained release of for moderate and severe Alzheimer's disease, that is 23 milligram. Donepezil 23 milligram per day has greater cognitive benefits than donepezil 10 milligram per day. Increased incidence, but although there is increased incidence of GI side effects when increasing the dose of donepezil from 10 to 20. Now the interactions. Donepezil and galantamine are metabolized by cytochrome 2d6 and 3a4. So the plasma levels are increased by ketoconazole, itraconazole, erythromycin, quinidine, fluoxetine, and paroxetine. Although rivastigmine has almost no potential for interaction since it is metabolized at the site of action and does not affect the hepatic cytochromes. It should be used cautiously in patients with asthma, COPD, sick sinus syndrome, supraventricular conduction abnormalities, susceptibility to peptic ulcers, history of seizures, and bladder outflow obstruction. Now targeting glutamate, there is a progressive neurodegeneration of both cholinergic and glutaminergic circuits as patients transition from mild cognitive impairment to Alzheimer's disease. The neurotoxic A-beta plaques and neurofibrillin tangles release glutamate from the normal inhibition by GABA as GABA interneurons degenerate. If the plaques and tangles cause the steady leak of glutamate, this would interfere with the fine tuning of glutamate neurotransmission and interfere with memory learning, but not necessarily be damaging the neurons. But with the progression of Alzheimer's, glutamate release could be increased to a level that eventually kill off dendrites and killing off full neurons due to excitotoxic cell death. This is the neurodegeneration by the plaques. Plaques and tangles cause steady level of glutamate release. It causes excessive calcium influx in the postsynaptic neurons, and there is accumulation of free radicals which cause destruction of the neurons. Now the NMDA antagonists, these are memantine, reduce abnormal activation of glutamate neurotransmission. Memantine is a non-competitive open channel. That is, it only blocks the ion channels of the NMDA receptor when it is open. It is low to moderate affinity, voltage dependence, and fast blocking and unblocking kinetics. It blocks chronic glutamate release from having downstream effects. This stops the excessive glutamate from interfering the resting glutamate neurons' physiological activity, therefore improving memory. It does not stop all neurotransmission at glutamate synapses. That is, when a phasic burst of glutamate is transiently released during the normal glutaminergic transmission, this causes depolarization that is capable of reversing the memantine block. Memantine also has a sigma binding and the weak 5-HT3 antagonist properties. The starting dose of memantine is 5 mg daily and the usual or maximum dose is 20 mg daily. The minimum level of interval between dose increase is 1 week, where it is increased by 5 mg weekly. A Cochrane review of Momentum concluded that it had a small beneficial effect at 6 months in moderate to severe dementia, Alzheimer's disease. There is no beneficial effect in mild to moderate dementia or in vascular and Alzheimer's disease. Primarily non-hepatic metabolism, and it is renally eliminated. In combination treatment, according to NICE, it recommended the use of combination of acetylcholinesterase inhibitors plus memantine in patients with moderate to severe Alzheimer's disease, and there is no pharmacokinetic or pharmacodynamic interactions between acetylcholinesterase inhibitors and memantine. Moderate to severe, mild के लिए nice. When do we have to stop the treatment? Continued treatment with donepezil was associated with continued cognitive benefits. Therefore, patients should continue treatment with acetylcholinesterase inhibitors for as long as possible, and there should not be a cutoff MMSE score where treatment is stopped. The risks of discontinuation of dementia medication should be balanced against the side effects and cost of continuing treatment. The other treatments with less evidences are ginkgo biloba with no convincing evidence, vitamin E, folic acid supplementation, and vitamin B12, B6 improve the cognitive function by increasing the homocysteine levels, specifically people with high levels of homocysteine. Omega-3 fatty acids, pyridine, and dimbone, there is no evidence of improvement. In saffron, Crocus sativus, there is evidence of significantly improving cognitive functions in Alzheimer's disease. Cerebrolysin is a parenterally administered porcine brain-derived peptide preparation, which improved cognition in patients with vascular dementia. Sovinad is a medical food for the dietary management of Alzheimer's disease, but the evidence of efficacy is weak. Idalopyridine is a 5-HT6 receptor antagonist, and NSAIDs have no evidence of improving cognition. Trazodone and dibenzoyl methane the study was done in a prime disease mice. Both trazodone and dibenzoyl methane treatment restored memory deficits, abrogated development of neurological signs, prevented neural degeneration, and significantly prolonged survival. But there is no available observational data. Now, the NICE guidance for the treatment of non-Alzheimer's disease dementia. It offered donepezil and rivastigmine to people with mild to moderate dementia with Lewy bodies. Only consider galantamine for people with mild to moderate dementia with Lewy body if donepezil and rivastigmine is not tolerated. Consider donepezil or rivastigmine for people with severe dementia with Lewy bodies. Consider memantine for people with dementia with Lewy body if acetylcholinesterase are not tolerated or are contraindicated. Only consider acetylcholinesterase or memantine for people with vascular dementia if they have suspected comorbid Alzheimer's disease, Parkinson's dementia, or dementia of Lewy body. Do not offer acetylcholinesterase and memantine to people with frontotemporal dementia, and do not offer acetylcholinesterase or memantine to people with cognitive impairment caused by multiple sclerosis. These are the summary of recommendations by British Association of Pharmacology in Dementia, where in Alzheimer's disease, the first choice of drug is acetylcholinesterase inhibitors and the second choice is memantine. There is no drug of choice for vascular dementia and frontotemporal dementia, whereas in mixed dementia, dementia with Lewy body, and dementia with Parkinson's disease, the first choice of drug is acetylcholinesterase inhibitors and the second choice is memantine.
So in short, everywhere the choice is
As you
vascular or second choice,
Treatment of behavioral and psychological symptoms of dementia. BPSD includes aggression, agitation, vocalization, distress during care, disinhibition, hallucinations, delusions, apathy, low mood, and anxiety. There is no pharmacological treatment for either psychosis or agitation in dementia yet approved. Use of antipsychotic drugs is controversial because of the three reasons. It has effect size is small, tolerability is poor, and there is an association of increased mortality. Uh, so they are treated cautiously off-label with dopamine blocking drugs, especially risperidone for psychosis, olanzapine for aggression, and aripiprazole for overall BPSD, as well as haloperidol, but not quetiapine except at higher doses of 100 to 200. Haloperidol users had an increased risk of mortality, whereas quetiapine users has a decreased risk. Antipsychotics should not be used routinely to treat agitation and aggression in people with dementia. Due to the serious adverse effects of haloperidol, risperidone is the agent of choice, indicated for short-term treatment up to 6 weeks for persistent aggression and patients with moderate to severe Alzheimer's disease. The doses of risperidone recommended are it is licensed up to 1 milligram twice daily, although the optimum dose in dementia has been found to be 500 microgram twice daily, that is 1 milligram daily. Alternative antipsychotic drugs like olanzapine, quetiapine may be used off-label, off-license if risperidone is contraindicated or not tolerated. Now, the miscellaneous agents, the new therapeutic agents on the horizon separately and specifically target either the psychosis network, example, the 5-HT2A antagonist, which is pimavanserin, and the agitation network with multimodal glutamate monoamine agents such as brexpiprazole and dextromethorphan and bupropion combination. The formulation of dextromethorphan and norepinephrine dopamine reuptake inhibitors, bupropion, has promising results in agitation of Alzheimer's disease. Dextromethorphan bupropion blocks the excessive excitatory glutamate output from the agitation network that leads to motor and emotional agitation. Now, treating dementia, treating depression and dementia, the prevalence of depression and Alzheimer's disease comorbidity is estimated to be 30 to 50%. The evidence of efficacy of antidepressant in BPSD is mixed and limited, showing that antidepressants are less helpful for depression. Escitalopram may be effective in BPSD, but the evidence of sertraline is mixed. Trazodone 50 milligram at bedtime was noted to be well tolerated and improved sleep for people with dementia and insomnia, but at doses 150 to 300 per day was found to be effective in reducing BPSD in frontotemporal dementia. There is no significant therapeutic effect of 15 milligram mirtazapine on Alzheimer's patients with sleep disorders, and TCAs should be avoided in patients with Alzheimer's disease. Now, mood stabilizers in dementia, carbamazepine has the most robust evidence of efficacy in non-cognitive symptoms, but avoided because of the adverse effects. Valproate, oxcarbazepine, and lithium showed low or no evidence of efficacy. Low-grade evidence based on case series and case reviews suggests that a possible benefit of gabapentin and pregabalin in patients of BPSD and Alzheimer's disease and frontotemporal dementia. Limited evidence to support its use and may be justified where the other treatments are contraindicated or ineffective. So the valproate is best avoided. Behavioral disturbance. Melatonin, dementia and sleep. Melatonin results in there is evidence that evidence supportive. Risperidone is present. Melatonin results in improvement of day-night sleep, day-night time sleep ratio and decreased nocturnal activity. There is limited evidence to support the use of melatonin, but safe to use and may be justified in some cases where benefits are seen. There is non-pharmacological management of sleep disturbances should be tried first. Avoid benzodiazepines other than emergency sedation because of the increase in all-cause mortality. The recent advances are there was a development of a drug aducanumab, which was FDA approved in June 2021 for Alzheimer's disease, and it targets the aggregated form of the amyloid beta protein. Monoclonal antibody. Thank you. Combination. Yes, it is recommended to use combination rather than acetylcholinesterase alone. Inhibitors are first choice, but the evidence of efficacy with both combination is better than alone. Better to use both combination rather than even
Any type of dementia.
any time.
What is the treatment for
Symptomatic treatment. So symptomatic treatment.
Picture and slide. Once we mention every multiple sclerosis that I mentioned.
inflammatory disease
Comorbid one first में evaluation में देखो.
Dementia is not preferred in
Inflammatory condition. Gluten. Sodium. I also thought in sodium, but no mods means written that valproate should not be
because of side effects or because of no efficacy?
because of side.
No, we said because of no efficacy. Because of valproate, we said carbamazepine has good efficacy, but it has side effects.
Side effects
And other have
and
no efficacy. That's what we नहीं यहाँ पे लिखा है efficacy नहीं है side effects के बारे में वहाँ ये लिखो
no evidence of it.
watch करना है
But low evidence.
carbamazepine is avoided and it has no evidence.
Olanzapine can be. Olanzapine. Quetiapine can be on low efficacy. 100 to 102.
Higher dose. Higher
100.
dose.
15. But क्यूटायापिन का लिखा है एरिथ्रोजोल रिस्पेराडोन और
Also, we should be careful. These patients are more prone to side effects.
साइड इफेक्ट्स.
Last time पढ़ा था ना, life cycle side effects में वहाँ पे था कि जिनको कोई भी मतलब brain में disease हो जैसे तो maybe after RPA or anything like that or dementia, they are more prone for these life cycle. Because individual dementia में ना हमें और क्या करना है जैसे query कराया गया particular dementia में क्या करना है vascular dementia में क्या करना है so those will be like one class should be dementia is very commonly seen in fact vascular से ज़्यादा तो मैंने particular मतलब Alzheimer सबसे ज़्यादा है उसके बाद तो मैं particular देखा and those patients they are mostly young patients they come after some head injury or something and when you try to explain to the family that the prognosis is very poor it is very disheartening. Also, I've seen cases improve also for the dementia, like maybe after the edema subsides and all. Long term, there is some improvement, but not never up to the pre-morbid level of function. And I think neuro people must be seeing more cases of dementia. But absolutely already not. Nice presentation over. This topic is still there is a lot of research going on. I mean, the treatment is not as satisfactory compared to other disorders that we treat because it is mostly symptomatic and it is very important to psychoeducate the relatives because their expectations should be managed. जब हम दवाई लिखते हैं patients relatives might think that this will kind of improve the symptoms or the patient will reach the pre-morbid level of functioning. So it is very important to psychoeducate कि ये improve नहीं करेगा आगे बढ़ने का स्पीड को स्लो करेगा ऐसे भी नहीं बोलना है कि बढ़ने से रोकने वाला है ना नहीं तो 15 दिन के बाद वो आके आपके साथ में नाचेगा कि आपने तो बोला था रोकने वाला सो स्पीड को स्लो करेगा लेकिन ये पेशेंट को बहुत क्लियरली प्रोग्रेसेस बता देना है रिलेटिव को कि दिस इज काइंड ऑफ slowly progressing a degenerative disease हिंदी में and also like unrelated but kind of related the caregiver burden is also very high in dementia. A lot of studies have been done. I think it is one of the highest compared to all other disorders. So caregiver को भी जब हम patient को दवा लिखते हैं caregiver को भी we can kind of see if they kind of require some anti-anxiety or antidepressants or maybe just helpful counseling and realistic management of expectations. And also one thing we left in the treatment is behavioral aspect. पेशेंट को ओरिएंट कैसे रखना है डिमेंशिया के पेशेंट को टाइम प्लेस पर्सन से ओरिएंट कैसे रखना है हमें क्लूज छोड़ने हैं घर में है ना उसका एक अच्छा लीफलेट कोई देखे गया था डिमेंशिया डे पे कि हाउ टू ओरिएंट द पर्सन जैसे यू कैन पुट ऑन बिग कैलेंडर्स इन द हाउस व्हिच आर इजीली रीडेबल है ना
टैग.
हां पेशेंट में टैग होना चाहिए जैसे डायबिटिक में टैग नहीं होता कि मैं डायबिटिक हूं और कहीं हाइपोग्लाइसेमिया या शुगर साथ में जैसे पेशेंट का टैग होना चाहिए आपके घर में जिसमें डॉग्स है तो आपने रखा होगा है ना आई एम नॉट सेइंग इन अ डिरोगेटरी मैनर आई एम सेइंग इन अ प्रैक्टिकल मैनर ओके वैसे टैग्स होना चाहिए पेशेंट के साथ स्पेशली जो उनको एडवांस जो लोग भूल जाते हैं और दूसरी चीज घर में कैलेंडर्स क्लॉक्स और बीच बीच में पेशेंट को ना यू हैव टू टॉक टू देम एंड मेक देम ओरिएंट कि आज डेट ये है महीना ये है साल ये है ना एंड समटाइम्स इट्स वेरी कॉमन दैट पेशेंट्स विल मिस आइडेंटिफाई द रिलेटिव्स like वो अपने grandchild को अपना child समझेंगे because in their mind they are in their 40s or 30s okay so उसमें भी orientation करना होता है okay अप्रोच लगाते हैं एंड वेरी इंपॉर्टेंटली घर का माहौल मतलब घर के ज्योग्राफी चेंज मत किया करो आज टेबल इधर रखा है कल उधर रखोगे ऐसे नहीं करना है बीच बीच में वो हम नॉर्मल करते हैं ना कभी कभी घर में ओरिएंटेशन ऑफ फर्नीचर चेंज नहीं करना होता है so that there is a stability you know because pharmacotherapy is so limited these are the things which can provide some kind of support to the relative and patient but overall obviously the province is very poor and there are also many movies of मुझे लेकिन एक भी नाम याद नहीं आ रहा
Hmm. 50%. Notebook.
तो या मतलब but there are nice movies इसमें एक movie में ऐसा था कि the patient was getting very confused so she had this chess piece okay उनके पास एक chess piece था जो वुडन का था मतलब पुराना vintage chess piece था तो she was like कि उसने घर के हर तरफ chess piece छोड़ रखे थे for the very reason कि वो confused हो रही थी ना what is reality and what is her imagination so she was like if I can see a chess piece and hold on to it that is reality okay so that's how she was managing in the early stage when the patient is aware that they are losing their cognition but they are getting confused okay. So yes there are so many other nice movies and series also and dementia is increasing because obviously our life expectancy is increasing पहले इतने नहीं होते थे
Nice.
and because of life
Life.
so that's why we're seeing a rise in cancer and cancer is also because of lifestyle processed food overall nice any comments in terms इसको ऑनलाइन